Welcome to Nurse Tutor Video's NCLEX video review. I'm Judy Miller, and I'll be your guide as we go through the video review. This videotape is on the endocrine system. We'll be talking about the pituitary gland, the adrenal gland, the thyroid gland, and also about diabetes. To start our review, you'll take a look at the picture on the slide and notice a little tiny gland up in the brain. That's the pituitary gland, sometimes called the hypophysis. And just above the pituitary gland is the hypothalamus. Now if you look down to the neck region, you'll see the thyroid gland, shaped kind of like an H that surrounds the trachea on three sides. Moving on down, you'll notice over the kidneys the adrenal glands, sitting on top of the kidneys kind of like a little cap. And then you note the pancreas, from which we get insulin. And if you look down further, you will see the gonads. First, we're going to talk about the pituitary gland. And I'd like you to note that we have both the anterior and the posterior pituitary gland. If you look at the posterior pituitary gland, it secretes simply antidiuretic hormone and oxytocin. Antidiuretic hormone is the hormone that a hormone that helps to regulate fluid balance and sodium balance. Antidiuretic hormone, sometimes known as vasopressin, says to the kidneys, hold on to sodium and water. It's very important. You can't live without antidiuretic hormone. Oxytocin we think of predominantly when we think of labor process, because it stimulates uterine contractions. Now I want us to look at the anterior pituitary. And you can see from the list that there are a number of hormones that the anterior pituitary puts out. Oftentimes it's called the master gland. It puts out TSH, thyroid stimulating hormone, that tells the thyroid gland what to do. It also puts out another tropic or stimulating hormone, adrenocorticotropic hormone, which tells the adrenal cortex what to do. It will also put out growth hormone, which sometimes called somatotropic hormone, which tells the bones and muscles to grow. Another stimulating or tropic hormone that goes out is melanocyte stimulating hormone, which deals with skin pigmentation. In addition, we see a whole group of reproductive hormones which essentially tell the ovaries and the testicles to mature either the egg or the sperm. And these would include follicle stimulating hormone, interstitial cell stimulating hormone, luteinizing hormone, and prolactin. Before we get into specific disorders of the endocrine system and involving the pituitary, I'd really like to think a little bit about the feedback loop, because this is very important for us to understand how the endocrine system functions. If you look at the picture on the feedback loop, you'll notice that we have the hypothalamus and then we have the pituitary. The hypothalamus you might want to think of as a gland that has a bunch of dials and gauges up there. And if you think about the gauge that responds to, in this example, we're going to use thyroid hormone. So when the thyroid hormone level is low, the hypothalamus puts out thyroid releasing factor, which tells the anterior pituitary to put out thyroid stimulating hormone, which tells the thyroid gland to make more thyroxine, or T3 and T4. And when those levels in turn rise, it's like the thermostat on your furnace. It says, hey, we got plenty, and there's no thyroid releasing factor, and hence decreased amounts of thyroid stimulating hormone. This is called a feedback loop. And it works not only with the thyroid gland that we've used for the example, but it's also very important in the adrenal gland and most of the other endocrine system. This is a thought we want to keep in mind, because it's something I'll be referring to later as we talk about not only the thyroid gland but also the adrenal gland. Now let's move in and talk about some specifics related to the pituitary gland. We've talked about the hormones that the pituitary gland puts out. If the pituitary gland is in hyperfunction, and when we talk about hyperfunction of the pituitary gland, it's usually a secreting tumor, but it's benign. So you might see it referred to as a benign tumor or a benign adenoma. When there is a secreting tumor in the pituitary gland puts out more of the hormones that it normally produces. So that means that your person will have too much growth hormone. So in turn, if they were a child and their growth plates had not closed, they might grow to be 8 feet tall. If they're an adult and the growth plates at the ends of the bones have closed, then what's going to happen is that they're going to get growth where there's a lot of cartilage. So we might see things like elephant ears. They might look like Dumbo the flying elephant. They may have a large nose. Their jaw gets larger. Their hands and feet increase in size. So they have a very distinctive look. That's called acromegaly. In addition, they put out too much thyroid hormone, thyroid stimulating hormone, which makes the thyroid gland put out too much. So they may get symptoms of hyperthyroidism. They may get symptoms of hyperadrenalism or Cushing's syndrome. Most likely there will be reproductive problems. In essence, all of the hormones that the pituitary gland puts out are on overdrive. To diagnose this condition, the nurse would expect that the patient would undergo procedures to find the tumor. So that would be skull x-rays, CAT scans, MRIs to physically see evidence of tumor. One would also expect blood and urine tests to pick up evidence of increased secretion of hormones. The management of this is either to irradiate the tumor and shrink it and or surgery. And we'll talk about surgery in a few moments. The opposite condition that might occur is hypopituitarism. In hypopituitarism, we would see exactly the opposite symptoms. We would see too little of the growth hormone. Now, if it's a child, they'll be very small. If it's an adult, that doesn't play a major role for us. We might also see hypothyroidism. We might see Addison's disease, hypofunction of the adrenal cortex. Again, we could see reproductive problems. In addition, we would probably see things like a headache. The patient would complain of a headache because there's a tumor. We might also see visual disturbances because the pituitary gland is located right near to the optic chiasma where the optic nerves cross. The diagnostic studies to confirm the diagnosis of hypopituitarism would be very similar to those for hyperpituitarism. The skull x-ray, CAT scan, MRI to help locate the tumor if that's present, to help locate any problems within the brain itself, and then of course the blood and urine tests to pick up hormone levels. The management of hypopituitarism is hormone replacement. One of the key things that people like to ask nurses about hormone replacement is the fact that this will be every day of their life. In other words, it's something they never stop taking. So if you had a question about teaching related to this, one of the most important teaching things is that they will take this medication every single day. If they stop taking their medications, they die. They also need to have identification that identifies them in case of an emergency as taking these medications. That's absolutely critical in the teaching process. Let's talk a little bit about hypophysectomy. Now that's the word you want to remember because hypophysectomy is the term used for removal of the pituitary gland. I mentioned in the beginning that hypophysis is another name for pituitary. Actually, it's a fairly old-fashioned name for pituitary. But nobody talks about pituitaryectomies these days. They still use the old-fashioned term hypophysectomy. Now, if a hypophysectomy were to be performed, There are two ways that the surgeon might do it. In one way, the surgeon goes through the head and makes a craniotomy, if you will. And we have the usual care that we would for a craniotomy patient. The other approach is what's called transsphenoidal. And in a transsphenoidal approach, the incision actually goes in the mouth, just above the gum line, back through the sphenoid sinuses into the pituitary. Now the advantage to this, of course, is the patient doesn't have a hole in their head. The disadvantage is that the mouth is a very dirty place and they're at high risk for infection. So if we look at the picture in terms of nursing care for a hypophysectomy, let's look down at the things that are most important. Checking output is at the top of the list, and that's interesting. But remember that the posterior pituitary put out that antidiuretic hormone that we talked about. Antidiuretic hormone, if you don't have it, if it's removed and you don't have adequate replacement, this patient will put out large amounts of urine. That would make a nice nursing question, actually, in terms of essential assessments post-hypophysectomy. One would expect that the urine output may increase. Now, the patient will be given vasopressin as a substitute for the antidiuretic hormone. Next on the list, and right along with it at the top, is hormone replacement. And we said this will be every single day for the rest of their lives. Without it, they'll die. There's no way to survive without taking those hormones. The patient will probably be placed in a low Fowler's position, as anybody with, or almost anyone with a craniotomy will be. And you would do some teaching in terms of no bending and no coughing, no sneezing, not things that would reduce or increase intracranial pressure. If the client has had a transsphenoidal hypophysectomy, as you can see, there's a couple other things that we need to do. One of those is we would expect large amounts of antibiotics to be administered. You would be real concerned about just simple little things like no toothbrushing for the first few days until those sutures have been removed. We also might see questions about checking for cerebrospinal fluid leak. Sometimes when there's been a hole through the roof of the mouth, but that ends up going right back into the brain, there could be a CSF leak. We need to know this because if CSF is coming out, organisms are going in. And the way to pick up a CSF leak, if there's any secretions that you have any question about, remember to check it for glucose. CSF is positive for glucose, and that's the traditional test for cerebrospinal fluid. Now let's move on and talk about the adrenal gland. The adrenal gland is an absolutely fascinating gland. If you'll notice from the picture, it sits on top of the kidney, hence the name adrenal. Ad meaning to, renal, kidney. It's a separate gland from the kidney. It's not part of the kidney's function, although some of its functions help to regulate kidney function. As you remember, the endocrine system, those hormones go directly into the bloodstream. So these adrenal gland hormones go into the bloodstream. They don't go into the kidney itself. Now, if you look at the bottom part of that picture, you'll notice that there are two parts to the adrenal gland. There's the adrenal cortex, or covering, and the adrenal medulla, or middle. And these two glands have different functions. Now, I'd like us to look at what the functions are of the adrenal gland itself. And so if you look at the picture, you'll notice that the adrenal medulla puts out adrenaline. Imagine that. The adrenal gland puts out adrenaline or adrenaline. It's also called epinephrine. And this is your fight and flight response, your emergency response. Now let's talk about the adrenal cortex. The adrenal cortex is a bit more complicated. It puts out sugar, salt, and sex hormones. And this is a good way to remember it. The official word of the sugar hormones is glucocorticoids. Gluco, sugar. This is cortisol. And cortisol has three really main jobs in the body. One is the stress response. One is it's immunosuppressive and it's also anti-inflammatory. Now with the stress response, a part of that stress response is the conversion of glycogen that's been stored in the liver and the muscles into glucose for emergency energy, hence the term glucocorticoid or sugar hormone. As we all know, cortisone is immunosuppressive. It's used for all your autoimmune diseases. And as a part of suppressing the immune system, it decreases inflammatory response. Now let's move on and talk about the salt hormone. The salt hormone, sometimes called mineralocorticoids, if we want to be technical for it. The mineralocorticoid is aldosterone. Aldosterone says to the kidney, hold on to sodium and water and get rid of potassium. So it not only regulates fluid balance, but also sodium and potassium balance. And by doing that, it helps to regulate blood pressure. And the third type of hormone is sex hormones. Now, all of us, men and women alike, have both male and female hormones in our body. And to some extent, those come from our sex organs, either the ovaries or the testicles. We also have a secondary source of sex hormones, and this is the adrenal cortex. And everyone has both androgens, male hormones, and estrogens, female hormones, from the adrenal cortex. These are in part responsible for our secondary sex characteristics. Now that we've reviewed the major functions of the adrenal gland, I want to take just a moment and talk about the adrenal medulla problems. And there's really only one that we need to review. And that is pheochromocytoma. And as you can see from the picture, when you have a pheochromocytoma, oma is a tumor. So we have a tumor in the adrenal medulla. Now the adrenal medulla, as you remember, puts out adrenaline. So when you have a tumor in the adrenal medulla, you have too much adrenaline being produced. So this patient is going to have symptoms that are pretty predictable. They're going to have high blood pressure, and this high blood pressure doesn't respond to anything. It's very resistant to treatment. So it's one of those 10% of high blood pressures that don't respond well to treatment. They may also have tachycardia, they may have panic attacks, anxiety attacks, type of symptoms. And there is really only one treatment for that, and that is surgery to remove the adrenal gland. Now, I want to move on to the adrenal cortex. It's absolutely essential that you understand about the adrenal cortex, because when I talk about the problems associated with the adrenal cortex, you could see questions on this related not only to a primary problem in the adrenal gland, but these are also the side effects of steroid medications. And most of you are likely to get questions on your exam related to the side effects of steroid medications. So if we think about what the adrenal gland does, we just reviewed the functions. I want you to look now at the overhead, at the picture, and see what is involved with hyperfunction of the adrenal cortex. So let's kind of go through the sugar, salt, and sex hormones and review them in order. If you have too much sugar hormone, too much of the cortisol, one would expect the blood sugar to rise. And indeed it does. So we see a high blood sugar. One would expect increased immunosuppressive effects. And indeed this is what we see. So the patient who has too much cortisol, whether it be primary from a tumor or secondary as a side effect of cortisone, may have hidden infections, for instance, because they have such an anti-inflammatory response that they could have a raging infection and no redness, no signs of the infection. They're very susceptible to developing infections because of their immunosuppressive response. These are the same drugs that are given to combat rejection of organ transplants, for instance. We also tend to see easy bruising, or ecchymoses, in patients who have too much of the sugar hormone. And if that's not enough, they get a moon face. They begin to look like, well, like the moon, with a perfectly round face, the buffalo hump. And we also will see demineralized bones. If we move on and think about what would be too much of the salt hormone, too much aldosterone, they will retain sodium and lose potassium. So their blood pressure will go up, they'll get edema, fluid retention, and they would be at risk for cardiac dysrhythmias from the potassium imbalance. As if that weren't enough, with the sex hormone, we're going to see things like acne, mood swings, a deepening voice, particularly in women. Women tend to get hair, facial hair, and oftentimes even changes in libido or sex drive. Now I'd like us to look at a picture of Mrs. Cushing. Now this is in no means a real person, and I call this picture Mrs. Cushing because it really pulls together what we see in Cushing syndrome. And this is such an important one that I really want you to focus on those symptoms once again with Mrs. Cushing. If you'll notice this poor dear woman, she has a moon face and a buffalo hump. You'll notice that she has very ugly looking stretch marks. And these are not just ordinary stretch marks, they're red or purple or pink, variously described. She has truncal obesity. Her arms and legs aren't so fat, but the rest of her is quite obese. She has easy bruising or ecchymotic areas. Her blood sugar is apt to be up. She develops brittle bones. And now if we move on and look at what happens with too much of the salt hormone, she gets high blood pressure, she's edematous, she has fluid retention, hypokalemia, which can cause muscle weakness, cardiac dysrhythmias, and of course a whole lot of fatigue. In addition, if we look at what happens from too much of the sex hormone, this poor woman has a little bit of male pattern baldness. She may develop acne, and if you look carefully at the picture, you'll see one on the end of her nose. Hirsutism. She develops a beard. Hirsutism means excessive hair growth. And in fact, if you look at pictures of bearded ladies in the circus, you'll note that most of them probably have Cushing syndrome. She may develop a great big deep voice, more characteristic of a male voice. She may also have a change in libido or sex drive. What I suggest that you do is really focus on this picture of Mrs. Cushing. And I often tell my students to take a mental snapshot of Mrs. Cushing. So you might do that now. Just look at her and go, take a mental snapshot of Mrs. Cushing. So that every time I say the word Cushing syndrome, poor Mrs. Cushing will come to your mind. This is so important. I really want you to have a memory tool for poor dear Mrs. Cushing. I'd like to do a question for us. So if you'll take a look at the question that's on the screen, and I'll read it with you. A 42-year-old woman is admitted to a medical floor. Nursing assessment reveals the following data: moon face, buffalo hump, 2+ pedal edema, truncal obesity, blood pressure 150/100, pulse 106 per minute. Important nursing interventions for this client should include which of the following? Number 1, applying cocoa butter to abdominal striae. Number 2, providing a high-calorie, high-fat diet. Number 3, preventing exposure to harmful organisms. And number 4, providing a low potassium diet. Now this question is interesting. If you'll note from the symptoms, they don't ever tell you exactly what this client has. As a nurse, you should be able to pull those pieces together, and I'm sure you did as you were reading that list of symptoms. About the time you came to buffalo hump, you said Cushing syndrome. Now, look in the stem of the question. It says important interventions, and that's a key word for us. So as we look at those choices, you might say that applying cocoa butter is not going to hurt her, but it's not important. So that's not the correct answer. If you remember the picture of Mrs. Cushing, she definitely does not need a high-calorie, high-fat diet. So that's not the answer. Number 3, preventing exposure to harmful organisms is the answer. She is immunocompromised, and we need to teach her and to help her to avoid exposure to infection. And of course, we always look at all the answers in every question. If you look at number 4, a low potassium diet is incorrect. She needs a high potassium diet. The aldosterone causes her to lose potassium. Let's do another question. If you look at the next question, the nurse is caring for a client who is admitted with Cushing syndrome. The nurse overhears the client arguing with her family. She says, "Why don't you just leave me alone? I didn't ask you to come to the hospital to see me." The client's husband becomes very upset. What is most important for the nurse to discuss with the client's family? 1, the need to restrict visitors to 1 at a time. 2, the need for a psychiatric consult to explore past events. 3, alterations in behavior due to the client's disease. Or 4, the client's extreme need for rest at this time. Now, if we pick apart the question, we know the client has Cushing syndrome, and she's got very irritable behavior, which is really quite characteristic of Cushing syndrome. So the best answer for us is number 3, alterations in the behavior due to the client's disease. We want to let the family know this is the disease talking, not really their loved one. After she's been treated, then if she's still irritable, then it's their problem. But at this point, it becomes the disease talking problem. Now let's move to one more question. A 38-year-old woman is admitted to the hospital for an adrenalectomy. She has a buffalo hump, pendulous abdomen, and ecchymotic areas on her arms and legs. Which statement would the nurse expect this client to make? Number 1, I feel faint between meals. Number 2, my husband and I have been fighting a lot lately. Number 3, I have a big lump in my throat. Or number 4, my skin has turned darker recently. If we take a look at that, she is admitted for an adrenalectomy, and we're given the fact that she has symptoms of Cushing syndrome, a buffalo hump, pendulous abdomen, ecchymotic areas. These suggest to us that the reason for the adrenalectomy is Cushing syndrome. So when we analyze this question, we're looking for factors that are consistent with Cushing syndrome. And the one of those, of course, is number 2. My husband and I have been fighting a lot lately. That's another way of describing mood swings, and that would be due to too much of those sex hormones. Now, I always like to take a look at the other distractors. Number 1, I feel faint between meals. You might want to think about that and think, what endocrine condition would we see a person feeling faint between meals? And that, of course, would be hypoglycemia. Mrs. Cushing, or this client who for an adrenalectomy, is likely to have hyperglycemia, not hypoglycemia. I have a big lump in my throat is much more apt to relate to a thyroid problem. The adrenal gland has nothing to do with the throat. And my skin has turned darker recently is suggestive of hypofunction of the adrenal cortex, not hyperfunction. And this is really a good way to make us start thinking about hypofunction of the adrenal cortex, which is the next topic that we want to talk about. So if we look at the picture really showing us about hypofunction of the adrenal gland, we can notice that with the adrenal cortex and hypofunction, we have too little of the sugar, salt, and sex hormones, too little of the glucocorticoids, or too little cortisol, is going to lead to low blood sugar and certainly low energy levels. Too little salt hormone, too little of that mineralocorticoid aldosterone, remember, aldosterone is the one that regulates sodium, potassium, and fluid balance. So if we don't have enough aldosterone, the client will retain potassium but lose sodium and water. And as they lose sodium and water, they're going to become hypovolemic. Their blood pressure will drop. They tend to go into hypovolemic shock. So someone, and we call this Addisonian crisis. They also may have decrease in the number of sex hormones and changes in their sex drive, although these are certainly not the most critical symptoms that the patient faces. If we think about the nursing care of a patient who has Addison's disease, want to think about some of the additional symptoms that we see and some of the care we need to give. We said they're fatigued, they have muscle weakness, a low metabolism, low blood sugar, low sodium, hypotension. The potassium is high. Now that puts them at high risk for cardiac arrest, cardiac dysrhythmias. And to get to the one where we talked about changes in skin color, they end up with increased amounts of melanocyte-stimulating hormone, and remember, that was what regulated pigmentation. Most of these patients will tell you, if they're light-skinned patients, they're going to tell you that they have a bronze color to their skin or they have a perpetual suntan. If their skin is darker, they may note areas of darker pigmentation than they normally have. And the reason for this would appear to be that feedback loop that we talked about earlier, remembering that when the adrenal cortical hormones are low, the hypothalamus is going to say, boy, we need more of these, and put out releasing factors to tell the anterior pituitary to put out more of the stimulating hormones to make the adrenal cortex put out its own hormones. In the process, melanocyte-stimulating hormone is increased with the result of increased pigmentation. Now, the nursing care for someone who has Addison's disease, or particularly if they're in Addisonian crisis state, is hormones. Now, the physician, of course, will order, but one would expect that the patient would be getting cortisone and Florinef, which is a mineralocorticoid. Until the patient is getting these hormones in sufficient amounts, usually they'll be given IV to start with, this patient needs to be at rest because they have no ability to fight stress. So in the case of Addisonian crisis, the priority is the medications, not the bed bath, not hygienic care, it's medication until the balance has been restored. Now, patients who have Addison's disease are going to be able to live a relatively normal life once they're regulated. Just to give you a little perspective on that, John F. Kennedy, who was the President of the United States, had Addison's disease. He had atrophied adrenal glands. And he certainly was able to function and accomplish things in life. Now, let's talk a little bit about a patient who might have an adrenalectomy, have the adrenal gland removed. As you might think, the nursing care for a patient with adrenalectomy, in addition to routine postoperative care, is going to be hormone replacement. And this hormone replacement will be every single day for the remainder of their lives. Generally speaking, when we are giving replacement hormones, either following an adrenalectomy or for the treatment of Addison's disease, one would expect that about 2/3 of the dose would be given in the morning and about 1/3 in the late afternoon. Now, this tends to follow the body's normal production of adrenal hormones. Part of what wakes you up in the morning is the fact that your body is automatically putting out more of these adrenal hormones early in the morning. In fact, as a little side note, disruption of the diurnal variations is what makes shift work very difficult, because you're trying to wake up at a time when your hormones tell you to go to sleep, for instance. A couple other things that are important when we're administering steroid hormones. Steroid hormones have a tendency to cause ulcers, so we usually give it with food or milk to reduce the gastric irritation. It's important to note also that if you're giving steroid hormones not as replacement hormones, but for a treatment, for instance, that the rules are a little bit different in terms of timing of the administration. If a person were getting steroid hormones perhaps to prevent rejection or to treat an autoimmune disorder, the dose is usually given in the morning, because that's when the hormone levels are the highest naturally, and that's when they're going to have the least effect on that feedback mechanism that we talked about at the beginning of our discussion. One other thing about steroid hormone administration that's critical for us to talk about: when patients are getting steroid hormones for treatment of a condition, say to prevent rejection following a transplant, or maybe treatment of an autoimmune disorder, or even treatment of poison ivy or bee sting, they're usually given a fairly high dose to start with, and when the doses are going to be discontinued, they have to be gradually tapered. Because if you remember that feedback loop, when you give a high amount of medication, it's going to shut off the stimulus for the anterior pituitary to tell the adrenal cortex to make its hormones. So we need to gradually reduce the amount of steroids, otherwise the patient goes into Addisonian crisis. In essence, what's happened is when you're on exogenous from outside the body hormones, the gland goes on vacation. And we need to give it a little time to pick up functioning again. Questions about steroid medications are fairly common questions. Now, just to reiterate another point, when you give steroid medications for any length of time, the side effects are going to be Cushing's syndrome. So you would expect someone who is taking cortisone or prednisone for a long period of time to get the moon face and to begin to look like poor Mrs. Cushing looked. That's one of the reasons that we cannot give cortisone under normal circumstances for long periods of time. Now let's move on and talk about another gland. This time I want us to talk about the thyroid gland. And you need to note that the thyroid gland surrounds the trachea on three sides. If you see in the picture, it looks kind of like an H around the thyroid gland. What I'd like to do is talk first about some of the diagnostic tests related to the thyroid gland, because there's some nursing care that's related to these. Patients who are being diagnosed or worked up for thyroid problems may get thyroid scans or radioactive iodine uptake studies. There's a couple of rules about this. Now, one, of course, they're iodine-related studies. So if you're doing an iodine study, you've got to ask the iodine question, which is, are you allergic to shellfish? Because shellfish have high quantities of iodine. So if the patient says, yes, every time I eat shrimp or lobster or crabs, I end up with a tight throat and hives, and one time I even went into shock, then this patient should not be getting iodine diagnostic tests. Another key element about these diagnostic tests for thyroid condition is that those tests using an iodine base should be done prior to any other test using an iodine dye. Now let me repeat that. Tests like a thyroid scan and a radioactive iodine uptake, which are essentially seeing how the thyroid gland processes iodine, because remember, thyroid hormones contain iodine. Iodine is essential to make thyroid hormones. These tests, the thyroid scan or the radioactive iodine uptake, must be done prior to any other study using an iodine dye. For instance, if they were going to do a cardiac catheterization on the client, or if they were going to do gallbladder x-rays, or maybe any other kind of arteriogram, all those studies use an iodine dye. Once that iodine dye is in the system, it stays in the system, and it can be as long as 6 weeks before you could get valid iodine or thyroid studies. So be sure that you schedule those studies first. Any patient that's getting studies like a thyroid scan or a radioactive iodine uptake needs to be told not to eat large amounts of iodine-containing foods for the first 3, 4, 5 days before that test, because that also could make the results invalid. Now, as we start to talk about the problems related to the thyroid gland, what I'd really like to do first is review the function of the thyroid gland and do it from the perspective of hypo and hyperthyroidism. So if we take a look at the first picture up here, we'll notice that we see hypothyroidism. In hypothyroidism, the metabolic rate is very slow. And you can see the picture over there of a pile of wood and a very, very slow burning fire. You can almost see the flame in that fire. This represents the slow metabolic rate. Metabolism or metabolic rate is how rapidly you burn fuel. So the fuel is burned very, very slowly. The heart rate is very slow. The patient may have a heart rate of maybe 50, probably not up to not above 60, and maybe even lower than that. Now, if the heart's beating slowly, the respiratory rate will be slow. Usually heart rate and respiratory rate go together. But the respiratory rate will be slow because they're not using up much oxygen. Remember that metabolism or burning fuel requires oxygen. If you're not burning much fuel, you don't need much oxygen. The body temperature is low. People who are hypothyroid will tell you they're always cold. Their hands and feet are cold. Everybody else is saying, turn on the air conditioning, and they're saying, give me a sweater, give me a blanket, please. Hypothyroidism, we see very low activity levels. It's all they can do to get out of bed in the morning. In addition to that, we tend to see slow function of the GI tract. These people are much more apt to be constipated because things move very slowly through the GI tract. Now, if they aren't burning fuel, as you can see from that picture, the fuel tends to be stored, and it's stored as fat. So people that are hypothyroid tend to be overweight. These people look at a half a leaf of lettuce and gain weight, practically. About the only thing that goes up, as we said with these folks, are their weight, and also they do tend to have heavy menstrual flow. Now, let's take a look at the flip side of that and see what happens to these factors when we're talking about hyperthyroidism. So take a look at the hyperthyroid picture. You can see here a very rapidly burning fire with a very rapid flame. The metabolic rate is very fast. You're going to see a very rapid heart rate. In hyperthyroidism, with this rapid metabolic rate, the heart rate may be up to 100, 120, occasionally even as high as 150. The respiratory rate tends to go up, so they're breathing much faster because they've got to oxygenate this rapidly burning fire. The temperature goes up. They're always hot. Phew, phew. You know, open the window. Turn on the air conditioning. They're always hot. Their activity level is up. They feel this kind of need to move around. They tend to have tremors oftentimes. They may be always on the go. Now their muscles may indeed get very fatigued, but they're always on the go. They just kind of have this nervous kind of energy, if you will. The GI tract is very rapid. They're more apt to get diarrhea. You also notice that these people are actually, you know, they eat constantly and never gain any weight at all. They're just always chowing down and never gaining weight at all because of the very, very rapid metabolic rate. So you can see that they're very, very different from those hypothyroid people that are very slow metabolic rate. Now, the only thing that tends to go down in the hyperthyroid patient, as we said, is weight. And also, they often get to the point where they are close to starving. And in women, we tend to see a decrease or absent menses with that. So, now, if we look at the next picture where we actually see the comparison between the hypothyroid patient with the very slow metabolic rate, slow heart rate, and the hyperthyroid patient with a very, very, very rapid metabolic rate who is always on the go, always busy, always doing things. So you can see that they really present very differently. I want you to look at another picture now, and I want to compare the eyes. So if you look, and you'll see on the left, this is this poor Ms. Edema. She has myxedema or hypothyroidism. Notice here that her eyes, you almost want to put toothpicks to open up her eyes. And she also, you can see, has quite a fat face in there. And if you look on the other side of the picture and see this man with Graves' disease or hyperthyroidism, his eyes are boing, buggy out eyes. He has exophthalmos or buggy out eyes. And this is very, very characteristic of hyperthyroidism. It's quite easy to tell when you look at someone whether they're hypo or hyperthyroid. So now that we've looked at a general comparison of the two conditions, I want to take out and talk a little more about each of these. And the first thing I want to do is have you look at this photograph of a patient. And if you look at this patient, you'll notice immediately something a little strange about her neck. This is indeed a goiter. Now, goiter means an enlarged thyroid gland. This woman probably has a simple goiter caused by lack, probably a combination of some genetic factors and a lack of iodine in the diet. This woman happened to live in an area where there wasn't a lot of iodine in the diet. And of course, iodine is necessary to make thyroid hormone. Now, just before we talk a little more about that, if you take a look at that picture again, you notice this huge, huge goiter on her neck. I wonder how she sleeps. Just from a nursing care's perspective, do you think this woman is going to sleep flat on her back? I don't think so. That's something to think about when you're thinking about caring for patients and positioning patients. She's either going to have to be with her head somewhat elevated or possibly lying on a side. But she's not going to be able to lie flat on her back. This particular patient probably will be given thyroxine in some form. She'll be given hormone replacement for that. And we may attempt to shrink the thyroid gland, and at some point they may operate and remove it. At this point, it's probably a little large to be safely removed, and they will give some medication to shrink that thyroid gland. Now, let's start, let's do a question. Let's do a question about a client with mixed edema. So if you look at the question, the nurse is caring for a client with a probable diagnosis of mixed edema. What would the nurse expect in the initial nursing assessment? Choice number 1, the client is underweight. Number 2, the client has tachycardia. Number 3, the client reports scanty menstrual flow. Or number 4, the client's temperature is 96.4 degrees Fahrenheit. So if we look at the question now, the problem is mixed edema. And mixed edema, remember Ms. Edema on the picture, she is hypothyroidism. And the only answer then it relates to hypothyroidism is choice number 4, the low body temperature. The other 3 all relate to hyperthyroidism. The hypothyroid patient would be overweight, have bradycardia, and heavy menstrual flow. Let's do another question. An adult woman has been hospitalized for 3 days with mixed edema. The nurse makes the following assessments: respirations of 8 per minute, diminished breath sounds in the right lower lobes, rales in the left lower lobe. The most appropriate nursing intervention is, number 1, encourage coughing, turning, and deep breathing. 2, encourage frequent rest periods. 3, initiate postural drainage. Or 4, continue with routine nursing care as this is expected. Now let's pull the question apart again. The client has mixed edema, that we know that that's hypothyroidism. And if you look at all the symptoms here, they're consistent with that, aren't they? Slow respirations, diminished breath sounds, and she's already starting to get problems because she's got some rales in one of the lower lobes. So, if we look at the options, encourage coughing, turning, and deep breathing. This relates directly to the issues in the question, doesn't it? Which were respiratory in nature, the slow respiratory rate, and the diminished breath sounds. A good possible answer, but always look at all the choices. Answer number 2, encourage frequent rest periods. You don't need to encourage rest periods for this woman. She's going to be resting all the time because she has no energy. You would encourage rest periods in the hyperthyroid patient, but the hypothyroid patient doesn't need to be encouraged to rest. Initiate postural drainage. A postural drainage would be done for people with pneumonia and chronic lung problems where they have large amounts of secretions. This person is not at that point yet, and that's not indicated. Now the answer that gives a lot of people trouble is choice number 4, continue with routine nursing care as this is expected. It is true that these symptoms are consistent with hypothyroidism, but routine nursing care, we need to do something to prevent complications. One of the things I always say about test items is the answer must relate to the question. And in this case, the symptoms were respiratory symptoms. Let's do the coughing, turning, and deep breathing that will help to prevent those respiratory complications. And one more question on the lady with mixed edema. So if we look at this question, the nurse is caring for a 58-year-old woman with newly diagnosed mixed edema. Because she is taking thyroxine, the nurse must be especially alert for which of these events? 1, respiratory compromise due to increased respiratory excursion. 2, cardiovascular compromise due to increased pulse and cardiac output. 3, metabolic compromise due to hyperglycemia. Or 4, metabolic compromise due to weight loss, nervousness, and insomnia. Now let's pull the question apart again. She is 58 years old. She has newly diagnosed mixed edema and is taking thyroxine. And we are told that the answer has to relate to her taking thyroxine. Every patient who starts taking thyroxine needs to be told that it can increase the heart rate. And I want you to think about patients who have myxedema. These are usually people who are overweight. They have poor, well, put it this way, they tend to have atherosclerotic fat deposits. They've not been metabolizing their fat, so that we're very apt to see atherosclerotic plaque. Now, when they're myxedemic, they have no energy and they don't stress the vascular system at all. Now you give them thyroxine, they have energy for the first time in months. They say, wow, I think I'll clean the house today. Start vacuuming, they start exercising, and suddenly those coronary arteries are now stressed and they may get angina. So the answer to this question is cardiovascular compromise due to increased pulse and cardiac output. We must teach each and every patient starting on thyroid hormone to report to their caregiver any signs and symptoms of angina. If they don't do that, they could end up possibly with a heart attack. They also need to look for any signs of tachycardia or rapid rhythms, because these can occur when they are given thyroid hormone. Now, just a couple other thoughts about the administration of thyroid hormone. This is usually given in the morning. It doesn't make sense to give thyroid hormone in the evening. If thyroid hormone is going to pep them up and raise their metabolic rate, you need to do it in the morning when they're going to be active with that. There are a number of forms of thyroid hormone. That is something that the patient and the doctor will work out together. We've already talked about most of the teaching related to that. Report any signs of cardiac problems, and we must teach them never to abruptly stop the thyroid hormones, because once again that feedback loop that we talked about in the very beginning comes into play. If they abruptly stop the hormones, then they lose. Remember that the thyroid gland has kind of gone on vacation itself because it doesn't have the TSH, and so they lose their thyroid is on vacation, and they're going to be going into a myxedemic crisis. So never abruptly stop the hormones. If they need to change the dose, they're always going to do it slowly and gradually. In fact, when the dose is started, it's usually started with a small dose and then gradual increments over time, rather than trying to start at the high dose. That reduces the cardiovascular side effects from that. All right, now, if you should have a patient who had myxedemic coma, this would be myxedema in the extreme. And in myxedemic coma, this coma is unusual in that these patients, one of their cardinal signs is that they're cold and their heart rate is very, very slow. And that helps to distinguish it from other types of coma. They need to be rewarmed gradually. Their metabolic rate is so slow that if you warm them up too rapidly, it will be too much for them to tolerate. Let's talk a little bit now about the opposite problem. When we were talking about the functions of the thyroid gland, we talked about hyperthyroidism. We often refer to that as Graves' disease. And as you remember from looking at the pictures a little earlier, they have a very, very rapid metabolic rate. Now, quite often what we see in patients that are developing Graves' disease is we begin to see a weight loss, and oftentimes they get quite slender without trying to lose weight. They may become even more adamant about their aerobics or their exercising because of this rather nervous energy. They may have tremors, they may be quite irritable, and as the disease progresses, you may see the exophthalmos, with the eyes beginning to bug out. We think that we see this very commonly in middle-aged women, women in the 40s, 50s, and sometimes on up into the 60s. And this is probably an autoimmune process that's going on. Sometimes people will refer to this as thyrotoxicosis. If a patient presents with this, obviously they're going to do the test to try and confirm the diagnosis, and those tests will include those earlier ones that we talked about with the radioactive iodine uptake or the thyroid scan. They may also do T3 levels, or TSH levels, or we can do T3 and T4 levels for that matter too, and they'll be high. But the TSH is an important one for us to think about, thyroid stimulating hormone levels. If the patient is hyperthyroid, the TSH levels will be low. Remember the feedback loop. If they've got extra hormone being produced, then the TSH levels tend to go down. If they were hypothyroid, the TSH levels would tend to be up. Now the treatment for this patient, once we suspect that they may indeed have hyperthyroidism, even before the final diagnosis is made, it's not uncommon for the patient to be placed on a beta blocker drug, for instance. Now, these are heart drugs, but the purpose of those drugs is to slow down the heart rate. And this is critical because if you've got someone with a heartbeat of 120, 150, they can get into serious cardiac problems with that rapid heart rate. So you may see them put on Inderal, propranolol, some one of the beta blockers to slow the heart rate. Once they confirm the diagnosis, there are essentially a couple of ways that treatment may proceed. You may have a patient that has ordered for them a drug like propylthiouracil, PTU, which is an anti-thyroid medication. This tends to block the production of thyroid in the gland. This isn't prescribed as much as it once was, but it certainly can be prescribed. And it reduces the size of the thyroid gland, reduces the vascularity of the gland. Much more commonly, what we see is radioactive iodine therapy. And in this therapy, the patient will be given radioactive iodine capsules, which will actually go to the thyroid gland and essentially kill it, shut it down. Then following the shutdown of the thyroid gland, this patient now becomes hypothyroid, and then they're going to be on thyroid hormone replacement for the rest of their lives. So they may go from a skinny size 2, now when they become hypothyroid after their radioactive iodine capsules, and this will take a few weeks to get there, but once the thyroid gland is killed off, then they may be back up to a size 10. So they're going to see some changes in weight and changes in energy level. We might also see surgery being performed, and a thyroidectomy might be performed for these patients. We'll talk about a thyroidectomy in a moment. I'd like us to do a question about thyroid function. So, if you take a look at the question, a 40-year-old woman is admitted to the hospital with severe apprehension, tachycardia, fine tremor of her hands, increased appetite, but progressive weight loss. The tentative diagnosis is hyperthyroidism. Which of the following would the nurse not expect to be present in this client? Number 1, amenorrhea. Number 2, diminished deep tendon reflexes. Number 3, muscle weakness and fatigue. Or number 4, profuse perspiration. Now, we're going to pull the question apart just like we've been doing on all of them. Now, she has severe apprehension, tachycardia, fine tremor, progressive weight loss, hyperthyroidism. Those are characteristic symptoms of hyperthyroidism. And the stem of the question here is a little bit crazy. Not expect. So in this woman, we would expect amenorrhea. That's not the answer. What about the deep tendon reflexes? Choice number 2. We would expect in hyperthyroidism that there would be exaggerated deep tendon reflexes, and this answer says diminished. So this might be the answer, but we're going to check them all. Choice number 3, muscle weakness and fatigue. Now you say, well, I thought she was always busy, but she is always so busy that her muscles get very weak, and indeed she has fatigue, but yet that kind of urge to keep moving. So that's not the answer. And profuse perspiration, indeed she'll have profuse perspiration. So the one she will not have is diminished deep tendon reflexes. Now you need to be careful when you get these knots in the stem, because they are ones that can easily trip you up. A clue for you might be when you look and see that a couple answers look correct, like amenorrhea and profuse perspiration. If you think they're both right answers, then you better go back and read the question again to make sure you picked up the knot in the stem of the question. Let's look at another question. Which nursing care measure is essential because a patient has exophthalmos? Now remember, exophthalmos is buggy out eyes. Choice number 1, administer artificial tears. Number 2, encourage the client to wear her glasses. Number 3, promote bed rest. Number 4, monitor pulse rate every 4 hours. So because the client has exophthalmos, it is essential to, number 1, administer artificial tears. As you remember, it is absolutely essential that you have a layer of tears over your cornea, otherwise your corneas will dry out and you'll go blind. If your eyes are bugging out, the tears, you don't have this layer of tears, so that artificial tears may be very necessary for this patient. The others are not particularly relevant to the exophthalmos. Now choice number 4, where she has a monitor pulse rate every 4 hours, that's probably appropriate for this patient. And also number 3, promote bed rest, because the patient probably has hyperthyroidism, because that's where we most often see exophthalmos. This, however, is not the appropriate answer, because the question said because the patient has exophthalmos. So make sure that the answer relates to the question. Let's take a look now at thyroid storm. Thyroid storm is really almost what the name says. It's thyroid hyperthyroidism in extreme. Probably the most life-threatening problems that occur with a patient in thyroid storm are cardiac problems, because the patient has got such a very rapid heartbeat, they can get into severe difficulties. They can also have a very high temperature. The temperature can go up as high as, say, 106 Fahrenheit. They can develop respiratory distress and ultimately get delirious and go into coma. So thyroid storm is a serious problem. Most of the time, your major nursing concerns, of course, are going to be basic stuff, patent airway, ventilation, oxygen if needed. The medications are probably going to include antithyroid drugs, steroid drugs, cardiac drugs, again, things in the beta blocker range to slow down the heart rate, and probably sedatives to slow down the whole metabolic rate. Thyroid storm is a serious problem, really an emergency situation. Let's move on now and talk about thyroidectomy. Ectomy, of course, is the removal of. So thyroidectomy is the removal of the thyroid gland. And this can be done either partial, which may be referred to as a subtotal, or complete, which may be referred to as a total thyroidectomy. In preparation for the thyroidectomy, we want to get the patient in as stable a status as possible. So if your patient is hyperthyroid, they will probably have been on antithyroid medications. We may have been trying to increase their weight because they're usually quite underweight at that point. Let's turn to a question. Before I give you all the answers, let's turn to a question. If we look at the question, the nurse is planning care for an adult who had a total thyroidectomy this morning and has just returned to the nursing care unit. In addition to checking the operative site and monitoring vital signs, what should be included in the nursing care plan? Choice number 1, monitor urine output every hour. Number 2, frequently ask the client her name. 3, teach the client about thyroid medication. And 4, place the client in Sims position. So let's analyze our question. We're going to pull it apart like we usually do. Total thyroidectomy. Notice the time frame. This morning, and has just returned to the nursing care unit. So we're talking about immediate postoperative care. And we're told, in addition to doing the usual things like checking the operative site and the vital signs, what should we do? So if we look at our choices, monitor urine outputs every hour. There is no pressing need to monitor urine outputs every hour. We'll do regular intake and output, but it needn't be hourly. The thyroid doesn't particularly affect urine output. Frequently ask the client her name, and this is the answer to the question. And the reason is that close to the thyroid gland is the laryngeal nerve. And one of the complications of thyroid surgery can be damage to the laryngeal nerve. So we don't want them to talk a lot. They're going to have a sore throat. So what we do is ask them something simple like their name. And if they suddenly start talking like this, then we know that there may be damage to the laryngeal nerve. So if they get sudden hoarseness, and you'd want to notify the physician. Choice number 3 said teach the client about thyroid medication. Now this is certainly important to do for the client, but not now. She's just returned to the nursing care unit. This has to be done prior to discharge, but this is too soon. She'll not remember anything you tell her anyway. And place the client in Sims position. Sims position, as you recall, is a flat position on the left side. This patient needs to be in a semi to high Fowler's position to prevent edema at the operative site and reduce the risk then of interference with breathing. So the correct answer to this question was to frequently ask the client her name to assess for possible damage to the laryngeal nerve. And while we're doing questions, I think it'd be a good idea for us to do one more. An adult woman had a total thyroidectomy this morning. Which would be the greatest cause for concern to the nurse during the early postoperative period following a thyroidectomy? Number 1, temperature of 100.6 degrees Fahrenheit. Number 2, a sore throat. Number 3, carpal spasm when the blood pressure is taken. And number 4, complaints of pain in the area of the surgical incision. Now let's look at the question. Total thyroidectomy, early postoperative period. So that sets us in the time frame. Temperature of 100.6. We can't get too excited about a temperature of 100.6 because this is quite normal in the early postoperative period. A sore throat. We really aren't excited about a sore throat. Anybody who's had a general anesthetic is likely to have a sore throat because they were intubated during surgery. So this in and of itself is not a problem. Carpal spasm when the blood pressure is taken. You might want to look as I demonstrate what a carpal spasm is when the blood pressure is taken. You pump up the blood pressure cuff, and it usually takes several minutes, so it may take 2 or 3 minutes. Then the hand goes into spasm. Carpal refers to hand. This is a sign of hyporeflexia and would be a sign then that there had been, that we had loss of calcium and probably inadvertent damage or removal of the parathyroid glands. And that is the answer to the question. The last choice in the question was about pain in the area of the surgical incision. Pain in the immediate post-op period is a given, so that's not something that we're most concerned about. We are, however, concerned about signs of hypocalcemia, which is manifested by tetany. Now I want to show you why we're so concerned about that. So you might want to take a look at this next picture where we see these 4 little brown beans. And these 4 little brown beans are the parathyroid glands. This is a posterior view of the thyroid, and these little beans are the parathyroid glands. Parathyroid glands regulate calcium and phosphorus balance. During thyroid surgery, they are sometimes inadvertently either damaged or removed. Now, to assess for the possible problem with a calcium imbalance with damage or removal of the parathyroids, we do 2 tests. One is the Trousseau sign that I just demonstrated for you, pumping up the blood pressure cuff and getting carpal spasm. That's a classic test for tetany or hypocalcemia. The other test is to tap the facial nerve, and you'll see the patient have an exaggerated response. So you tap the facial nerve and they grimace. That's another classic sign, and that's called Chovstek's sign, C-H-O-V-S-T-E-K, Chovstek's sign. These would be important to assess in all of your post-thyroidectomy patients. And in fact, we'll have at the bedside calcium to be administered on the doctor's order, usually intravenously, in case the patient develops tetany. Let's take a look at another slide here that kind of summarizes the care of the thyroidectomy patient. If you look at this slide, you can see in the preoperative the things that we talked about earlier, that you'll give PTU, propylthiouracil, or Lugol solution. Now, Lugol solution we didn't mention earlier, but this is a supersaturated potassium iodide solution. And PTU and Lugols can be given to shrink the thyroid gland and make it less vascular. Or we might give the I-131, the radioactive iodine, which also helps to make it, to shrink the thyroid gland. We want the patient in as stable a cardiac and nutritional status as possible prior to surgery. Now look at the postoperative side on that. And we'll just kind of run down those things that we talked about in relationship to those questions. We put the patient in a semi-Fowler's position. That's, of course, to prevent edema and swelling at the surgical site. It's important to check the dressing. Now you're going to check the back of the neck. Even though the surgery was on the front, if you're sitting in a semi-Fowler's position, the law of gravity is going to make it go to the back of the neck. Anytime you have surgery, remember there is edema in the site, and so we want to prevent complications related to that, and the thyroid surrounds the trachea on 3 sides. So we want to prevent any respiratory complications. So trach, oxygen, suction at the bedside, usually for 48 hours until that risk of edema has passed. And we check for tetany, which we just discussed, with the Trousseau sign, the carpal spasm with the blood pressure inflation, and Chovstek's sign, the tapping of the facial nerve and the grimacing response. And we keep the calcium at the bedside. And we talked about checking the laryngeal nerve for hoarseness. These would all be very important postoperative assessments to make for the thyroidectomy patient. We also want to encourage this patient, when they turn in this postoperative period, to turn so that their head and neck is moving as a unit. In other words, they need to turn as a body here, not doing this kind of stuff, because their incision is in this area. We want to take a brief look at problems with the parathyroid gland. We mentioned when we were talking about thyroidectomies that the calcium imbalance problems related to the parathyroids. Now, parathyroids are probably unsung heroes in the body, and they're not something that we tend to see a lot of questions about on NCLEX. But if we think about the functioning of the parathyroids, they regulate calcium-phosphorus balance. And remember that when we're talking about serum calcium, the calcium is either in the bones or in the bloodstream. So if we have a patient who has hypoparathyroidism, that means that there is a decrease in the serum calcium. And this causes the tetany symptoms that we just talked about with the thyroidectomy. The treatment for it is clearly to give calcium. In acute situations, it can be given intravenously, and in the long haul, patients are usually on oral calcium medications. Just a couple of other thoughts about the calcium. Remember that when you administer calcium, you frequently give vitamin D, because vitamin D enhances the absorption of calcium. And we might also see the patient getting aluminum hydroxide gel. This would be something like Amphagel or Gelusil, because these drugs actually decrease phosphorus levels, and we're talking about calcium-phosphorus balance, so they decrease the phosphorus levels. The other thing that we see with the parathyroid glands would be hyperparathyroidism. This is not a real common problem, but certainly can occur. Oftentimes we see this in, again, middle-aged people, frequently women, but also men can develop it. In hyperparathyroidism, we have high levels of serum calcium. Now, if the serum calcium is high, remember, then the bone calcium will be low because it's been pulled out of the bones. So patients with hyperparathyroidism would be then at high risk for easy bone fractures, for instance, pathological fractures. We also would note that if you have high serum calcium, the patient's at high risk for kidney stones, because the calcium may precipitate out and form stones in the urine. Patients that have hyperparathyroidism may be given IV saline, they may be given diuretics, and you need to be really careful in terms of bone care, because they're very prone to fractures. Now, let's move now and talk about diabetes. We want to talk about diabetes mellitus. And let's play with the word a little bit. Diabetes is a word that means increased urine output. Most of us didn't know that, but it means a lot of urine. And mellitus means sweet. The word that is sometimes confused with that is insipidus, which means tasteless. Now, diabetes insipidus, or lots of tasteless urine, would occur with problems with the posterior pituitary, where you didn't have enough antidiuretic hormone. Diabetes mellitus is where we have a lot of sweet urine, a lot of urine with a lot of sugar in it. Now, before we start talking about diabetes mellitus, I'd like to review a little bit about how this whole insulin works in the body. So if we look at the first picture here, this is a rather of a strange picture, because you see the G's over here representing glucoses in the bloodstream. Then you see a cell, and the cell has little hooks on it, if you will. These are insulin receptors. And you see a key. The key represents insulin. And you might think of those hooks, padlocks if you want, that. And what insulin does is it takes glucose from the bloodstream, goes to the cell, unlocks the door, if you will. It's picked up by the receptors, and you just picture that key as unlocking the door to the cell and putting the glucose in the cell where it can be metabolized. So the job of insulin then is to take glucose from the bloodstream to the cell for metabolism. And this is what it normally does. Now we'll take a look at the next picture, and we'll note that there's something missing in this picture. You can immediately see that what's missing is the key. In this picture, there is no insulin. So the glucose can't get to the cell for metabolism, and of course it builds up in the bloodstream. This is what we see with type 1 diabetes, insulin-dependent diabetes mellitus. Their lack of insulin. And if we look at the next picture, you can see this one looks a little bit different. What we have in this picture is a couple of keys, but those receptors, padlocks if you will, or receptors on the cell, are few and far between. And this is type 2 diabetes, or non-insulin dependent diabetes mellitus, the kind that we normally see as people age. So type 2 diabetes is more related to the lack of or the inefficiency of insulin receptors. There may be insulin in the body, and there is insulin in the body. It's just that the cells can't pick it up and can't use it. So we can see that there are really two different problems with diabetes, and there are some real differences then between type 1 and type 2 diabetes. Now let's talk about a couple other differences between type 1 and type 2 diabetes. Type 1 diabetes, as we've seen, is lack of insulin. Type 1 diabetes usually onsets early in life, anywhere from early, toddlerhood on up, usually before the age of 40. I have seen children as young as 2 with type 1 diabetes, but the most common time would be adolescence and young adulthood. So anywhere from the teens to the 20s or 30s, but anywhere. It used to be called juvenile diabetes. That term is not used as much now, mostly because while it onsets while they're juveniles, they continue to live with it for the rest of their lives. So insulin-dependent diabetes mellitus onsets at an early age. It tends to onset much more acutely. In other words, at some point, the pancreas, the islets of Langerhans in the pancreas stop producing insulin, and the patient goes very rapidly into ketoacidosis. It tends to onset, as I said, rather dramatically. In fact, if I were working in an emergency room and there was a young adult that came in unconscious with no history of a head injury, high on my list would be, does this patient have diabetes mellitus? Type 2 diabetes tends to onset much more gradually. This is what we see in people 50, 60 plus on up. And because these patients don't develop ketoacidosis as rapidly, they tend to live with the problem. So they tend to onset more with, they go to the doctor and say, I don't see very well these days. I think I need my glasses changed. And the doctor says, ooh, come back and see me after you've got your diabetes regulated. Or the lady goes to the gynecologist and says, I have a terrible yeast infection. And then they pick up that it's due to diabetes, because we tend to see a lot of yeast infections in diabetes. Or possibly the person goes to the doctor because they have a bad sore on their foot and it's not healing very well. And so then they discover that they have diabetes. So type 2 diabetes tends to onset more gradually, tend to be over the age, usually over the age of 50, but certainly over the age of 40 most often. And type 1 onsets more abruptly and onsets early in life. We need to look at some of the diagnostic tests related to diabetes mellitus. One of the most common tests is the fasting blood sugar. You may see that referred to as FBS or FBG, fasting blood glucose. Normal values are somewhere in the 70 to 110, 115 milligrams range. Another test that is often used is a 2-hour postprandial glucose. And postprandial means after eating. If you look at the values on that test, you'll notice that the patient's values should be somewhere not above around 140 or so milligrams per deciliter of glucose 2 hours after eating a heavy meal. Patient eats a heavy meal, then comes and gets his blood work done. The gold standard for diagnosis of diabetes is the oral glucose tolerance test, sometimes referred to as GTT. In this one, the patient comes fasting. Fasting blood work and urines are done, which should be within the normal range. And then they are given 100 grams of dextrose, real sicky sweet liquid to swallow. And blood and urines are done at 30 minutes, 1, 2, 3, and 4 hours following that. The values on the screen show you the normal curve. They should rise to not more than 200, and then by 2 hours be down in the 140 or less range, and by 3 and 4 hours into normal. Diabetics start higher, go higher, come back slower. And the hemoglobin A1C is a new test, relatively new test added. This test is what I call the you can't cheat test. This is based on the fact that hemoglobin or that glucose attaches to hemoglobin. This is sometimes called the glycosylated hemoglobin test. And this measures the glucose in the bloodstream for for several weeks, up to 2 to 3 months worth of glucose. So this is the you can't cheat test. Patient goes, and it doesn't matter what they ate for their last meal. This is going to say what's been going on for the last several weeks. A very valuable test. If the levels are above 6.5 for a prolonged period of time, the patient is at much higher risk for those complications of diabetes. One thing that we can sometimes pick up with the changes in blood sugar levels is something called the Somogyi effect, S-O-M-O-G-Y-I, the Somogyi effect. And this occurs when the patient has too much insulin. And it works kind of like this. The patient has too much insulin, drops the blood sugar too low, so you'll pick up very low blood sugars. And then the body's defense mechanisms kick in, which raise the blood sugar high. So this is kind of a rebound hyperglycemia to an overdose of insulin. And this is something that we need to watch for in our patients. Now, I've talked about ketoacidosis, and before we go into the management of diabetes, I really want to pull out and talk about integrate pathophysiology and kind of take it right through to the complication. So, if we take a look at this picture, you can notice up in the right-hand corner of the picture, there's just a little box that tells us about the normal, and it shows that insulin takes glucose into the cell. And that's just to remind us about normal. And if you look on the left-hand side of the picture, you can see the bloodstream and a few glucoses in it and a cell. And you notice there's no insulin. Well, that means that the cells are not getting glucose. And they're saying, hey, I need glucose. I got to work here. I need my sugar. So the body says, don't worry. We'll take the first line of defense, which is to convert glycogen stored in the muscles and also in the liver into glucose. So the body converts glycogen to glucose, increasing the number of glucoses in the bloodstream, also making the patient hungry as the glycogen stores are depleted. The only problem is there's still no insulin. So the cells are still screaming for glucose. So if we look at our next picture, what we can see is that we have all this glucose in the bloodstream. Still no insulin. The cell's screaming for glucose. So the body says, okay, we'll do the second line of defense, which is to convert fats into glucose. So the body converts fats to glucose. But in the process of converting fats to glucose, we get fatty acids or ketones. And this is what causes the acidosis and the ketoacidosis that we see in patients who have type 1 diabetes. Now, remember that when you have ketoacidosis, the way to get rid of the acid, the body is going to try and vomit out acid because the stomach contents are acid. So the patient probably will vomit. That you can breathe off acid. Carbon dioxide is acid, so the patient will develop air hunger, and they will develop small respirations to compensate for their acidosis. And they will have ketones in their urine, and they will try and urinate off the acid. Now we have a patient who has lots of glucose in the bloodstream and is now into ketoacidosis. We're not quite finished with problems at this point. So if we look at the next picture, what we're seeing is all this glucose with no place to go because there's still no insulin. This glucose in the bloodstream raises the osmotic pressure, which will tend to pull fluids from the cells. And the patient now begins to develop cellular dehydration. So they become dry and warm and flushed. And all this fluid that's been pulled in the bloodstream is going to go out through the kidneys. So they develop polyuria. And of course the polydipsia from the dehydration. So now we see our characteristic 3 polys that we think of with diabetes. We have polyuria, polydipsia, and polyphagia, or increased hunger. So that, in a very little nutshell, is what happens when the patient develops ketoacidosis. Ketoacidosis is what we see most commonly in type 1 diabetes. Now think for a moment about the type 2 diabetics you have seen. Are the type 2 diabetics skinny or fat? Usually they're on the fat side or heavy side. Type 2 diabetics don't break down fats very well. So type 2 diabetics tend to do the first step, converting the glycogen to glucose. When they get enough glucose in their bloodstream, they tend to get the third step with the increased osmotic pressure and the thirst. So your type 2 diabetics get the 3 polys, but they seldom go into ketoacidosis. This is why you can have a type 2 diabetic with a blood sugar of 600 or 800 drive to the doctor's office, or a type 1 diabetic with a blood sugar that high would be unable to get behind the wheel of a car. They might, in fact, might even be comatose. And so there are some differences in the type 1 and type 2 diabetics. I think it's time for us to do another question. And I want you to look at this question. A young adult is admitted to the emergency room unconscious. The client is dry, flushed, and has a sweet smell to his breath. There is no report or evidence of head injury. What information is most essential to obtain from the family members who came with him? Does he have diabetes? When was his last drink? Does he have a thyroid condition? Has this ever happened before? So let's take the symptoms. Unconscious, dry, flushed, sweet smell. The sweet smell is probably acetone, the ketones. And he's a young adult. No head injury. The best answer is, does he have diabetes? And this will lead us much more quickly to being able to treat this patient. And indeed, this is often how they present. Now, treatment for this patient would include hydration. It would also include, of course, insulin. And insulin is the mainstay of treatment for type 1 diabetics. It's essential that we be comfortable with some of the types of insulin. So if you look at the chart now, and you can see that we've got rapid-acting insulin and intermediate-acting insulin. And these are the two that are really important for you to know for the test. Rapid or regular, sometimes it's easy to remember, they're both R words. Rapid or regular insulin onsets very quickly. If it's given sub-Q, it onsets within a half an hour to an hour. If it's given intravenously, it onsets immediately. You need to know peaks. Peak means when it has the maximum effect, and it's peaking in 2 to 4 hours and lasts around 6 to 8 hours. After that, it's no longer effective. They might ask you questions about this, particularly in relationship to something like the patient received regular insulin at 7:30 a.m. When would he be most apt to develop a hypoglycemic reaction? And you remember that the hypoglycemic reaction is going to occur at peak action time, because that's when the insulin is taking the glucose out of the bloodstream the fastest. So if it were regular insulin, the answer would probably say mid-morning. Now if we look at NPH insulin, we note that NPH doesn't even kick in for 2 to 4 hours. It peaks in 6 to 8 hours, about the time that regular is quitting, and lasts all day. So if the question was asked about when would you expect to get hypoglycemic reaction from NPH insulin, the answer is going to be something like mid-afternoon in your 6 to 8 hour time frame. And usually questions will use terms like mid-morning, mid-afternoon, rather than pinning you down to an exact hour, because the variations, and they'll depend upon the exercise and what the patient's eating and so forth. So the mainstay of treatment for type 1 diabetics is going to be insulin. They also will be on a diet. When we talk about insulin administration, there are a couple of things that we need to be concerned about. Insulin is administered subcutaneously. Usually we use a very short needle. So when it's given sub-Q with a very short needle, it's usually given at a 90-degree angle. The only problem with this would be if you have a very skinny patient. And if they're very skinny, then you might need to use a 45-degree angle with the insulin. We have long been taught about administering insulin and rotating sites. You need to remember that good sites for insulin can include the arm, the abdomen, and the thighs. Now, if we do the abdomen, we stay an inch away from the umbilicus. We want to rotate sites so that any one particular site is only used once every couple of weeks or so. However, when you rotate sites, many experts today recommend that you rotate within the same area, so that if you're using the abdomen, that you use the abdomen sites. And then when you move to the thigh, you use the thigh sites. You don't go abdomen, thigh, abdomen, thigh. If you are using, for instance, an arm site and someone's going to be doing heavy working, you might want to use the non-dominant arm, because if that muscle is being exercised, you're increasing that uptake much more quickly, and you may indeed predispose them to some of the side effects of the medication. In regards to the administration of insulin, I think we need to look at another way insulin is administered with insulin pumps. We're beginning to see more insulin pumps being used in the management of type 1 diabetes particularly. If you take a look at the picture I have here of an insulin pump, you'll see that the insulin pump is a small device. It's actually about the size of a little bigger than a credit card, but the size of a small handheld calculator, to give you a reference point. And in the pump is a syringe that contains usually about 3 milliliters of insulin. And depending upon the client's insulin needs, this is probably enough for 2 or 3 days worth of insulin. And you can see that there's a catheter, and there's various kinds of needle arrangements or catheter arrangements. This is put in the subcutaneous area in the abdomen so that the patient then doesn't have to give himself a shot every few hours as they do when they're administering it in the normal subcutaneous manner. And this is set up so that the syringe gradually dispenses insulin during the course of the day, much like the pancreas normally does that. Many people who have a hard time maintaining control do well on insulin pumps. You might note that most of the pumps also have a little button that can be pushed for a bolus, so that just before a meal they can get a bolus of insulin. And it acts much more like the normal body acts with that. Now, let's take a look at a question. Question says, the nurse is teaching an adult patient self-administration of insulin. The instructions should include teaching her to 1. Inject the needle at a 90-degree angle into the muscle. 2. Vigorously massage the area after injecting the insulin. 3. Rotate injection sites. Or 4. Keep the open bottle of insulin in the refrigerator. Now, if we look at those answers, self-administration of insulin, answer number 1 is not correct. The 90-degree angle part is fine, but it doesn't go into the muscle. It goes into the subcutaneous tissue. Number 2, we do not massage insulin. Number 3 is the answer, rotate sites. We just talked about that. Number 4, keep the open bottle of insulin in the refrigerator. You may keep the extra bottles in the refrigerator, but the open bottle can be kept at room temperature. And that's better for the patient because they really don't like to get cold injections. We need to talk a little bit about insulin reaction or hypoglycemia that can occur. And with many patients following the administration of insulin, if the insulin is at peak time or acting too much, it can lower the blood sugar too dramatically. When the blood sugar is lowered, you need to be alert for the signs and symptoms. These patients are confused. They're pale, they're cold, they're clammy, they're sweaty but cold. And confusion, hunger, pallor are all symptoms of hypoglycemia. And you need to know, of course, that what we do for it is exactly what you'd expect. We give them some sugar, so give them some juice. You don't have to add extra sugar to the juice. Just give them juice. If they carry tablets with them, they can carry the tablets. A favorite question might be that the patient is unresponsive or unconscious, is a known diabetic, and has those symptoms of pallor and diaphoresis that we just mentioned. In this case, you do not give them juice to drink because they're unconscious. So look for that in a question. You can't give them juice if they're unconscious. What you would do would be to take some frosting or some of their gel that they may carry with them and put it under their tongue where it can be absorbed. And then once they get awake, then you can give them some juice, and you could give them milk and a sandwich. Usually after we bring the blood sugar up immediately with a fast form of sugar like juice, then we give them a sandwich if they're not about to eat a meal. We give them something to maintain the blood sugar at safe levels. Hypoglycemia is a serious problem and one that you're likely to see a question about on the licensure exam. Now, a couple of other things that we want to talk about in the general care of diabetics would be things like foot care, skin care, because of course they're very highly susceptible to skin breakdown, and once they get an infection it doesn't heal very well. We also need to be alert for renal function because the kidneys are usually damaged with long-term diabetes. We need to be alert for cardiovascular disease because they're at high risk for cardiovascular disease. They're also at high risk for neuropathies. The patient may have terrible pains in the legs, and this is due to neuropathy, high blood sugar levels, over a long period of time, damaged nerves and blood vessels. We want to look at one more group of drugs, and these are the drugs that are used to treat type 2 diabetes, the oral hypoglycemics. And if we look at the first picture, we can see that there are a number of categories of oral hypoglycemics. The sulfonylureas, these are the ones that have been around a long time. These are things like oronase, diabinase, but also micronase or diabeta, which we still see being prescribed for patients. We also note that we might see a category of drugs called the biguanides. This is metformin or glucophage. This is a wonderful new drug that has come out, and this drug actually increases the effects of insulin in the body. So this is used for type 2 diabetics. It, unlike insulin and the other drugs, does not make patients so hungry. So this has been a very good drug and a fairly recent drug. We also see used drugs like Precose and Glycet, which are in the category called alpha glucosidase inhibitor. And what these do is delay the absorption and the digestion of carbohydrates so that the blood sugar doesn't rise as quickly after meals. It doesn't do anything for insulin, but it just kind of regulates the rise in blood sugar. And the last and newest category of drug is the drug it's in the thiazolonidone category. It's called Resulin. And Resulin, again, reduces the amount of glucose in the system. It seems to potentiate the action of insulin in the skeletal muscle and decreases glucose production in the liver. Very, very helpful drug, used a great deal today, and many patients are now being able to be maintained with these drugs, with the Resulin or the glucophage, that could not be well regulated with the other kind of oral medications. A couple other things that we need to talk about, and that is the diet in your diabetic patient. And there's several approaches to diet. The use of the exchange list has been around for a long time, where food is divided into the exchange groups, the milk, vegetable, fruit, bread, meat, and fat groups. The patient is assigned how many servings from each group they're allowed. And once they know what foods are in each group, they select their diet from those foods. And that's been around for a long time and is still being used for a number of patients. You might also see patients where they're looking at the glycemic index of foods, and that is how big a rise in blood sugar foods cause. And so we're seeing some doctors will put a big emphasis on looking at avoiding foods with a high glycemic index. Generally speaking, this means that they're going to be on a high fiber diet, because fiber tends to reduce the glycemic index. Some doctors are simply putting patients on a high fiber, low fat diet, which essentially reduces glycemic index. So there are a number of ways that diet is managed. Generally speaking, we want to, if they're overweight, lose weight, maintain normal body weight, and get the nutrients that are needed, and avoid high blood sugar levels with that. Now, the care of your diabetic patient is a fairly complicated process. You may find that it's helpful to use as resources diabetic educators, many of whom are nurses. Sometimes they're dietitians. But these are people that are specialists in the area. Sometimes on an exam question, you might see a question that asks about what resources you would use. And in this case, we have experts in the field.